many years, having led the program in Delaware, which is one of the few statewide programs in the country. And I'll keep myself brief so that Peter can get started. I think we're all really looking forward to this. It's a wonderful note and end the semester on. So Peter, take it away.
Actually, before you start, Peter, just if
Sure.
we will do question and answer at the end. So if you guys could just put any questions into the chat, and then we'll review them and Peter will answer them when he's finished.
Yes.
Thank you.
Wonderful. Good morning, everybody, and thanks again for the invitation to speak. It's always exciting to get a chance to reach out to an audience that sounds like it's pretty varied. We've got folks who are coming in from the research perspective, and it sounds like some teachers and professionals and some parents, which is fabulous. So I'm going to talk today about policy opportunities and barriers to the implementation of evidence-based practices, and looking specifically at the example of interventions for severe aggression. And you'll see that, you'll see why I'm talking about that in a little bit. But a little bit about my background. So I have a kind of non-traditional background. I've spent about 23 years working very intensively in the field. I'm trained originally as a child psychologist. And most of that time was involved in either delivering services or supervising the delivery of services to people on the autism spectrum. So I began my career in setting up early intervention programs in Montreal at a psychiatric hospital, which is where I was trained and where I grew up. And then, as Fred mentioned, I then moved to Delaware and took charge of their statewide public school program for children with autism. And then since that point, I've had different kinds of work in university settings at University of Pennsylvania at the Center for Autism Research, and then at the A.J. Drexel Autism Institute, promoting different kinds of initiatives focused on training and dissemination of practice. And then, as Fred mentioned, also had the privilege of working with Fred and others to author some books on evidence-based practice and policy and program development. And then I also had a brief foray into the wonderful world of inpatient crisis treatment, setting up and running a program outside of Philadelphia. But over the past 6 to 7 years, I've kind of shifted focus to work more locally, and partly because I have a daughter who's 21, who's not on the spectrum, but has significant developmental disabilities. So I've been focusing on developing resources here. And had now some interesting experiences trying to help land conservancies develop more inclusive practices. That's the Open to All guidelines that we helped publish last year. And then launching some local programs here in Kennet, focused on getting kids with disabilities out onto trails. And then the Kennet Ability Network is what we're setting up for our daughter and for others that will create community opportunities for young adults with developmental disabilities. And this is my daughter, Margot, who is aging out of special education this year. This is us skiing at Gore Mountain, and I found an excuse to show you a video of this later on, and it is relevant and fun. So, so back to our topic. So, you know, I've been interested as kind of a service, as somebody who delivers services and oversees the delivery of services in this roadmap from research to outcomes. It's really what kind of got me interested in this field and led me to kind of to spend time both in the world of research and the world of service delivery. And so this simple diagram I pulled out of my 2013 book, and it really is meant to illustrate that research is never going to translate into outcomes unless it gets translated into training and policy and service and supports. So you always have to think, when you're thinking about research, you have to think about these other elements of training, services, policy, and advocacy, and how all these work together. Sometimes we spend so much effort on the research piece, we forget about the implementation, and that is a real challenge in many different settings. So when we talk specifically about policy, we can break it down into different dimensions and different levels. And there's more information on this in some chapters in the Handbook of Autism and a book that Fred put out, I think, last year from Cambridge. And we'll be talking about this in the upcoming handbook. So these dimensions of policy, and when I look at the opportunities, I kind of put things into these boxes that you can translate research into policy using practice standards. You have to think about the infrastructure of delivering services. How are these funded? What are the mandates of different professionals, and how do you provide oversight? And then, of course, how do you plan and coordinate the delivery of services and training and research? Now, there's also multiple levels of policy. And this is where there's lots of opportunities and challenges. So there's really policy happens at every level where a decision is made. So that can include at the national or the federal level, but both by the federal government, but also by agencies that are responsible for professional practice. So a group like the American Academy of Pediatrics, they have the potential to influence policy. But of course, in the United States, states have a big hand in just making decisions about how certain kinds of services are delivered, more so in education than in health, but they have a say in both. And then, of course, you have the local level, the individual agency that is, that in many cases is taking a leading role in the delivery of services. So that can include an individual school, it can include a school district, it can include a county level education program, or it can include a hospital or some type of community program. You also have decisions in the case of health services that are made by private organizations like insurers. You also have decisions that might be made by advocacy organizations in terms of what kinds of research they're going to emphasize or what kinds of services they're going to try to prioritize in their advocacy. In general, when you look at this, it's not surprising that at these higher levels of the national level or the federal level that you're going to get kind of broader standards without that level of detail. And so really the opportunity to kind of influence the actual delivery of services are really going to happen at the local level. So how can you identify the state agency or the school or the provider that is delivering services, and what are the opportunities that they have to deliver services differently? And these operational decisions are really important. Now, you can you can imagine when you're thinking about how to translate policy into outcomes, that you can imagine a grid where you have these different elements, different dimensions, and different levels, right? So when I look at when I imagine a program and try to say, like, what's the likelihood that it's going to have kind of broad impact, the more that this grid is filled in, the more optimistic I feel. You know, and it really is important now that we have more attention on traditionally underserved groups, because they're most often going to be left behind when you don't have these kinds of more comprehensive attempts to influence practice. So if we look at an example of this, and what's interesting is when you actually start to ask the question about, do we have examples of kind of policies that are implemented reliably across the country that are driven by research? It's very hard to find. And that reflects a lot of different factors. It reflects on the research, it reflects on the challenges of dissemination, it reflects the lack of coordination across different sectors. But here's one example where we do have these multiple levels, and that would be in individual education plans. Now, of course, the advantage here is, excuse me, is that IEPs are, driven by IDEA and its various versions. And so that makes it kind of unique. So we have a strong and very clear federal mandate for at least certain aspects of the educational planning process. And some of these elements really do translate across all the different levels. So if you look at something like, how do IEP meetings occur? These are referenced at multiple levels, at the national level, at the state level, at the local level. So in each of these levels, you'll find somebody talking about how IEPs should be done. And that's very important, because this is literally how the goals get set for, excuse me, for children with disabilities, how parents get engaged. It's, we might we might think of it as mundane, but it actually drives a lot of planning. So, so we can look at different aspects of the IEP process. We can look at the IEP meetings. We can look at the transition planning process of how do we get from services and the school system to services in the adult system. You start to get some standards in terms of how meetings should be done, and that's defined in regulations that you'll find at the state and the federal level. And then when you get into the more of the meat of it, the infrastructure, how all these things are funded, how do they operate, then you're getting into more of the kind of local decision making. You know, so you can ask a question about staffing, right? So why do we care about how IEP meetings are staffed? Well, if you look at what happens for traditional teachers, and if I could see all the teachers in the audience, you'd all be nodding. Nobody ever sets aside enough time to kind of pull the team together to put together a good plan, right? There's decisions that are made about how much time teachers spend in the classroom and how much time they get for planning. And so you see these gaps that are very important. And actually, we'll come back and talk about an example of that with respect to severe behaviors. So in this case, you do have examples of different policies that have impacts across all levels of the system. And again, just to emphasize what the potential for policy is here and how transformative it can be. If you look at what IDEA did, IDEA enshrined a major pivotal role for parents in educational planning, right? So that was set in the law, and that has had these huge downstream effects in terms of parental impact on planning that have not really been seen in any other country, because other countries don't have an IDEA with a level of protections. And so the federal law in this way was really transformative on giving advocates and parents the seat at the table. Without that, we wouldn't, the system for delivering education services would be very different. And, obviously it creates other challenges in terms of parents that bring schools to due process and are dissatisfied and want to promote practices that maybe aren't as effective. But it's also been the principal way that we've seen some important changes in educational practice. So this policy of kind of enshrining the role of parents in educational planning is really transformative. So let's shift gears and talk about what an evidence-based practice is. And this is a relatively straightforward definition that I've kind of evolved over the years. So I would define an evidence-based practice as a practice that results in outcomes that are clinically or educationally significant, that are superior to what people would get otherwise, what we call treatment as usual, right? So this is important because you can have something that yields a kind of theoretically significant change, but it doesn't mean that it's clinically or educationally or functionally significant. Practices do need to specify the methods that are used. That's usually pretty straightforward. The target of intervention, so what is the skill or behavior that one hopes to change, and the population who will benefit. And these are important because sometimes practices focus on very narrow targets and it's not clear to what extent they'll generalize. Well, if something is going to impact receptive communication, will it have any impact on expressive communication? And then the population who will benefit, that's really important because as it turns out, in many of these cases, these practices tend to focus on a subset, whether it's defined by a population that has certain kinds of prerequisite skills. So, one example being a practice that's going to benefit verbal but not nonverbal children, or populations that are defined by other characteristics. Now, the key thing in an evidence-based practice is we want evidence to be demonstrated by a series of outcome studies that are well-controlled and peer-reviewed. And, in here, when we talk about well-controlled, we are now looking beyond the traditional randomized double-blind placebo-controlled clinical trial that's been the gold standard in evidence. And in our work, we've been recognizing the benefits of single subject experimental design, which is what is the bread and butter of applied behavior analysis. That under the right conditions, that these can also yield practices that we would consider evidence-based. Now, that's not universally acknowledged. There are still groups out there that hesitate to embrace single subject designs. And the results is that those groups will tend to identify many fewer practices as evidence-based. But that's been a really important change in the field. When our first book came out in 2011, we were just starting to see some other groups that were publishing systematic reviews of research, namely the National Professional Development Group that's now at Frank Porter Graham in North Carolina, and the National Autism Center. But aside from those two groups, most of the other, especially medical-based professions, were still focused on, and many still are focused on, the traditional clinical trial as being kind of the only thing that recognizes something as evidence-based. And of course, we have the peer-reviewed step in here just as an additional check. That's not to say that peer reviewers all apply kind of rigorous standards, but it still is markedly superior to just having self-published research. And then, the main takeaway here is that we're gonna come back to is that we've seen many kind of statements about evidence-based practice that people are in support of it, but usually it kind of stops there. They don't necessarily take it to the next level to ensure that they identify and address all the barriers to implementation. And that's really what a lot of my work has been focused on in delivering services. What are those barriers? So when we talk about severe behavior, and let me just step back for a second and say what I mean by severe behavior. So I'm talking here about what would in most cases be aggression and self-injury that is significant enough to lead somebody to be placed in a less inclusive setting, right? So not mild aggression, but more significant aggression that could mean that a child is then considered no longer for a class in their local school, but is considered for referral to, say, a more specialized program where they're spending most of their day with students with different levels of disability. So in more restrictive settings, or in more extreme cases, they may be removed from their home, placed in some kind of private setting, whether it's a hospital or a behavioral treatment program. So I'm particularly concerned about this because in my work over 2 decades, I found that those were really the individuals who had obviously that were experiencing the greatest impact of their disabilities, but we saw tremendous impacts on their families and on the systems of care. And what tends to happen is that these individuals get shunted off into other kinds of settings where they're not necessarily going to get treatment that's going to allow them to come back into the community. So we worked hard to kind of deinstitutionalize individuals with significant levels of disability, and we've made a lot of progress, but there's still a lot of progress to be made. So to come back to kind of evidence-based practices, when we scan these different systematic reviews that have been done of the evidence, we can come back and kind of make these simple statements that behavior plans that are informed by functional behavioral assessment are recognized as successful in reducing many problem behaviors. And some of the techniques that can be applied across a broad range of behaviors and settings with a high degree of effectiveness includes things like differential reinforcement, which includes different techniques to replace the problem behavior with something that is more appropriate. And another set of interventions that we could call antecedent-based interventions. So these are things that we do beforehand to prevent the behavior from occurring. And all of these are techniques that can be used effectively across a wide range of settings. And especially when they're delivered by people who have the right kind of training, supervision, and these are delivered with the right intensity and level of oversight. So you can go back to the National Autism Center or the National Professional Development Center, and you'll find specific descriptions of these different kinds of evidence-based practices, along with lists of articles that describe the methods in more detail. So we can contrast this with things that are interventions that are used in many settings that are not as effective, but are still frequently used. So we can talk about one class of interventions that we can describe as different forms of aversive or even punishment, something as simple as saying no to something that is closer to looking like some form of punishment, like response cost. If you do this, then you're going to have to, you're gonna lose certain privileges, overcorrection, contingent work. There's a range of techniques that are less and less used in many settings, but in some settings, some staff still tend to default to these. The bigger one is the use of seclusion and restraint. When there's a concern that the individual is behaving in a way that's not safe to themselves or to others, could be physical restraint of having hands on a student or a patient to kind of keep them under control. Or it could be seclusion, putting them in a setting where they have limited access to others as a way of addressing safety concerns. We also have a lot of different medications that are used. I mean, the studies are pretty clear that when we talk about individuals with more significant levels of behavior, many of them are on multiple medications. And there are a lot of different medications that have been used in different ways to target aggression and self-injury with very variable degrees of success. So if you were to kind of do a survey of individuals with severe behaviors out in the community, and you were to look at their programming overall, my guess is that you would find that most of them would have one, if not more than one of these evident in their treatment over the course of a year, right? So, so the question is not just about what treatments do we prioritize based on their effectiveness, but what treatments do we look to kind of decrease? And there are challenges associated with both, because when you talk about things like seclusion, like medications, there are clearly times when those are appropriate and they're necessary and they're needed, but there's other times where they might be less effective than one of these other alternatives. So an example of a policy standard that we could look at that captures some of what I think is important for addressing these kinds of behaviors. A policy standard could read something like, for reducing severe aggression and self-injury, we set standards, we define standards that are derived from ABA-based positive and proactive intervention. And that includes the use of FBA, differential reinforcement, antecedent-based interventions, and there's others. And we prioritize these instead of using reactive strategies, and especially before relying solely on medication. And we do this to prevent seclusion, restraint, and removal from any homeschool settings when injuries occur. And we try to implement this across school, hospital, and community settings. So this is one slide, but it would take years to implement this systematically across the systems of care. But if we were successful in implementing this kind of policy standard, we would keep more kids at home with their families at less cost to the state and a higher quality of life for everybody. Okay, so it's these kinds of policy standards that really have the potential to be transformative for some families, and then the question becomes, how do we get at these? So, these first sets of standards are really driven by research, right? So we need to know what's going to work, what's going to be effective. And we can continue to look at research to provide more guidance, but ultimately we're going to also have to translate those research findings into specific training protocols. But these other elements are going to require more planning and oversight. How do we get a handle on what's going on in these different settings and begin to make changes in practice? So as I mentioned before, these are really important because we've seen these great strides made because of inclusion. That has been tremendous, but we still have a subset of children who are unnecessarily removed from their communities, whether it be their home or their school, and placed in institutional settings. They might not be the psychiatric institutions of past, but they're still settings where they're going to have limited contact with the community. And this is a real issue. And just to kind of give you a quick perspective, you know, my daughter here, Margot, probably had she been born 40 years ago, would herself have been institutionalized because she has pretty significant levels of intellectual disability, and she has a feeding tube, she has seizure disorder. So she's got some real challenges. And part of my decision to kind of shift my own work over the past couple of years is to kind of try to see what I can do to give her a quality of life. And so for fun, this is probably going to look pretty choppy, but this is Margot and I skiing this past winter. And it's one of the few it's one of these activities that really kind of transforms her quality of life. She's able to do something that she finds thrilling and exciting. In this case, it's something I'm doing with my family. And we've gotten to the point where we can do it independently without an adaptive ski program. And when in doing this, I basically relied on a lot of the evidence-based practices in behavior analysis to kind of shape her behavior and provide different levels of support. Now, we wouldn't normally think about skiing as being a practice we want to promote. But really, this is also fun because I get my kids involved. It's really hard to find activities that get the whole family involved. And this was the first thing, one of the first things we were able to do that we all had fun with, including my son, the cameraman. So, you know, so often we think about these, whoops, let's go to the next slide. We don't think about these quality of life issues, but they really are potentially transformative for kids when we can figure out ways to get them out and get them doing things that are exciting. Oops, let's go ahead. So when you talk about the research level, what are the things we could do? Well, right now, I think it's fair to say that there's really no national initiative that we have that's looking to identify and prioritize research to address these kinds of significant behaviors. Now, we do have more of a focus in the past 5 years on children who are minimally verbal, and that does get at a subset of this population, which is welcome because they've been traditionally underrepresented in research. But we still don't have any kind of national initiative to prioritize this. And when some of the work I've been doing involves looking at all the different research publications and grants that have come out over the last period of time. And there are very, very few that look at this population, and virtually none outside of the kind of single subject research design that look at it. We also have other kinds of research that can inform practice. We don't usually think of as evidence-based practice, but is another category of research that looks at the prevalence of a problem, and that's important in setting policy. If we knew how many children were still kind of unnecessarily institutionalized, could that change our policy priorities? It could, but the thing is, we don't do that kind of research. We don't have those numbers in front of us. So that is another kind of research that's not an evidence-based practice, but it's research that has the potential to inform policy. And you just have to look at the ADAM reports of the prevalence of autism to know how much these kinds of findings can influence policy. But we also have the potential for other kinds of research that just looks at rates of seclusion and restraint. So right now, the only efforts that I'm aware of are different kind of federal review panels that document incidents of seclusion and restraint with very negative consequences. But otherwise, we don't really have, to my knowledge, in many states, kind of systematic reviews for looking at the use of these procedures that are necessary in a small number of cases, but unnecessary in most. So we could have a national policy that kind of looks at the use of seclusion and restraint across different settings. There's some fundamental changes that we might need to think about in terms of how we do research. So I mentioned this controversy about single subject design. When you talk about research in these kinds of severe behaviors, there is almost no research published addressing these behaviors that is not single subject research. And to a certain extent, that simply reflects that these behaviors often have kind of multiple intersecting sources. And so it'd be extremely difficult and also ethically very challenging to do any kind of research but single subject. So we have to, it forces us to recognize that these other designs are important. But I also think that we could have a very helpful policy shift that looks at kind of more functional improvements based on systematic application of simple packages. So in my preparations to get my daughter ready for the adult world, there's a lot of evidence-based practices that I can draw on that come from good teaching practices of reinforcement and antecedent control and task analyses and prompting and understanding the things that trigger her behavior. And these are all in and of themselves individually simple techniques, but the trick is to really put them together in a package that works. And when it works, she gets access to settings that she'd otherwise be excluded from. Also, I think have implications though in terms of how researchers are trained, right? So to what extent do researchers get kind of real life experience in delivering services? And I think that can open their eyes, certainly open my eyes to the challenges of implementation, but I think it also opened a lot of people's eyes towards what our priorities are, that it might help us move away from some projects I'd call esoteric towards things that have kind of more functional application. So part of my work recently has been how do we develop trail systems and systems of support to get people out hiking, right? It's not a glamorous kind of target for treatment, but it is a really important one in terms of quality of life. And it's something that actually can be implemented relatively simply. But then we also have to think about how we do training of practitioners. So we have this step in kind of in the development of most professionals when they're getting ready for licensure. So to what extent do training programs assure that evidence-based practices are emphasized? And that includes a couple different pieces. So part of it includes helping people understand what is an evidence-based practice and how do we identify them. So I, for example, developed a couple of courses, graduate seminars, where part of it included kind of educating teachers on where to look and how to read a research study and how to kind of pull the information from a research study to identify what they might be able to use and how they can apply it. So giving people training in how to make use of the information that's out there, as well as, of course, knowing what practices are evidence-based. And then we can also just look pragmatically at the curricula. Are evidence-based practices trained first, right? Are they kind of prioritized? And one of the things that we run into is that there's a lot of things that people do where there isn't a lot of research supporting it. So if there isn't strong, well-controlled research to support a practice, are there other kinds of sources that we can still go to where we have confidence? And so, for example, in the current book that we're working on, when we ask the question, what are the evidence-based practices that a pediatrician can use? There's a lot of things that they have to do in their day-to-day life that they can't find an evidence-based practice for. And take an example of how do you identify accommodations that you can put in place in your office to make sure that parents feel welcome and they're not going to avoid coming to the office because it's a difficult experience for them. You're not going to find an evidence-based practice for that, but you will find different kinds of what I would call expert consensus practice guidelines. So things that they're not necessarily based on research, but you have a group of folks who are identified as experts in their field who assemble a list of simple practices about how to make pediatricians' offices more accommodating. And again, if somebody's not finding their pediatrician's office accommodating, they're not going to bring their child in for care. So there's a fundamental barrier that they're experiencing, but that's not really addressed by evidence-based practices at this point. And then, of course, you want to think about how do you implement these kinds of standards, not just in the levels of university courses for licensure, but also ongoing professional development, continuing education that might be specified at different levels. So we also have services. So we can make some broad policy statements that can be effective. So, in the case of seclusion and restraint, there's been broad policy statements that I think have been very effective in limiting its inappropriate use. And I've, had the experience of working with very challenging students in both the school and the hospital settings. And it's interesting to see that schools and hospitals look at this differently, but they both look at it. So we don't even have consistency of standards across school and hospital settings. We do have some guidelines where there's a general statement in support of evidence-based practice and some of the federal education laws. And I'm happy to say I managed to insert that into some Delaware education laws. The first time I tried to put evidence-based practice into state law, I discovered that the only other place that referenced evidence-based practice was waste management. So I figured we should probably try to get it in the care of our kids before we focus on other things. We do see some statements about the use of functional behavioral assessment in federal education guidelines, but I was also interested to see kind of some emerging reference in outside the US in the health services that start to talk about prioritizing behavioral treatment over medication. And I think also the AAP guidelines talk about this in a roundabout manner, but the UK, the NICE guidelines talk about this, which is interesting. And, these are things that you can implement across providers, especially when you're talking about school and hospital settings. Question though becomes oversight. Like, how do you provide some level of assurance that these things are actually being used? Well, you do have the potential for oversight for seclusion and restraint. And I've seen this implemented very successfully in school and hospital settings. And, so one of the things that's challenging is that this is a really difficult population to work with. And it's going to be inevitable that even the best team will sometimes be surprised. And so they need to be trained in things to keep kids and keep themselves safe. So I've always had a policy that everybody who's going to, work with kids has something in their toolbox to respond in a dangerous situation. But that being said, once you give that guidance, you need to have the mechanism to check that they're using it appropriately and to take action if they're not. I can't tell you how many people I've fired for making a bad decision. But this is a very challenging population. And so it puts us in these really difficult situations. But one of the biggest opportunities is to simply say, if you find yourself in a dangerous situation, that should trigger some kind of review of the behavior programming, right? And it should trigger a review pretty quickly. In the hospital setting, it had to happen within 24 hours or our licensure would get pulled. And I don't see any reason why you couldn't have a similar standard in school. To what extent could it trigger an independent review? Something that we did in Delaware very successfully. And so there's potential for oversight if you can build it in and get the appetite and the resources to do it. But I also like the idea of kind of strategic planning done well. And in the case of these kinds of severe behaviors, we can have all the techniques that we want, but if we don't implement them consistently across different settings, if we have a plan that's different in school from home, from the hospital, we're not going to see any progress, right? So, but there's these huge gaps in terms of coordinations of plans that I've experienced as a professional and a plan and as a parent. And that is something that can definitely be mandated, right? When you have somebody who is going to be considered for removal from their local school because of a behavior problem, has there been a meeting in which there's been coordination across the different providers where a physician is talking about the medication that they've considered, a wraparound service provider is talking about what's happening at home? And if you're at the point where you could potentially keep a child out of a private placement, but it requires more resources, could you have a county or a state level program that basically gives the thumbs up to put in additional resources, whether it's a direct service provider or additional specialized consultant? And of course, you also have the potential to bring professionals together to do cross training. The behavioral techniques that you use in a school and an inpatient program, there's a lot of overlap. And why not train people if they're going to be using similar techniques? And so, you know, having these state level policies to coordinate planning can really make a difference, I think. And that kind of active coordination is really, really important. And it is a huge gap. In the inpatient treatment program that I ran, you know, I would ballpark that about 30 to 40% of the patients had no coordination across their school and their wraparound service providers. We were often the first agency to bring everybody to the table and say, let's try stuff in a coordinated way. And we had the opportunity during the inpatient stay to actually, you know, look at medication, see what kind of role medication could play. And so we're able to do this in a coordinated way. But that becomes extremely challenging once you move outside into more rural settings, smaller school districts. You know, it's really difficult. So one of the opportunities is to look at, you know, designating agencies to take charge of this kind of coordination. And in a really well-run school, a teacher will do that, but it's really hard for a teacher to do that without the right level of training and support. This kind of active case management is a huge challenge. And so that's where you get to the final piece when we talk about policy. You know, we do talk about funding. Funding's a big piece of this. You know, it can fund staff time, it can fund training, it can fund targeted research. And one of the big questions that really research has not addressed very well is this whole question of intensity. We can think of it as dosage in the medication world, but when you talk about services, what's the intensity that's needed to turn a behavior around? You could talk about that with pretty much any intervention we're talking about. How often does this intervention need to be delivered in order for us to see progress? And how long before we start to see progress? It's one of the things that I like to train teachers in and reading an article, go through it. How many hours a day of instruction were required? After how many weeks were you going to see progress? And that could make a big difference in terms of your decision to continue to implement an intervention or not. And in many cases, finding that information about intensity and duration and rate of change is really, really hard in the individual research study. But you also get that in terms of training, right? So what level of coaching, what intensity of coaching do you need to have in order to help a teacher to develop the skills they need to be able to address some of these challenging behaviors? And that's really important because that's all about staffing, right? You have many great training programs out there, but they simply can't provide the level of coaching that's needed to translate what might be covered in a seminar like this into day-to-day practice. We just don't have that level of research on the level of training and support that's needed. And that in the case of severe behavior, we have an additional challenge in that these are relatively low frequency behaviors, which means that in a smaller school district, they may have one or two of these students over the course of 10 years. And so every time the student comes up, you know, somebody's got to reinvent the wheel. So we don't really have the infrastructure needed in many counties to be able to provide the more specialized support. And so school districts are left on their own, and they miss opportunities to kind of address some of these things early on. So some of this can get translated into kind of local and state policies that look at how we can use money flexibly to provide more intensive services, more intensive training, more intensive consultation. And also just in the case of when there are crises, where do kids go? As Fred and I were chatting just before we started, there's really very few crisis treatment programs in the US. And that's a real problem for kids whose behaviors do sometimes, despite the best efforts, spiral out of control. And for a period of time, whether it's 2 weeks, 3 weeks, the best, safest, and most effective place for them to be is in an inpatient treatment program. We just don't have those resources in many parts of the country. And that's something that states can play a role in kind of providing some seed money for. So let's end it there. That's a lot of stuff to cover, and I want to make sure that we have time for your questions. I always like to see what people are thinking and what they're interested in. So let's shift gears and see what questions we have.
So Peter, we got one question in so far, and others, if you can just type them into the chat function. And the person that asked, I'm not sure if they're still on, they were curious about the courses that you created for teachers, if they're still available, and if so, how one could apply to take them. So, yeah.
Sure. So, so I've had a couple different opportunities to teach teachers. The first one was when I was running the public school program in Delaware. Delaware is actually one of the few states that, well, at the time, and this has changed a little bit, but they actually had we had a required certification for teachers of children with autism. So they had to take a five course cycle. And there's all kinds of other policy barriers that occur there. Like we could, we set this up so that they would have to take these courses. And then we had to go back and say, well, let's make sure we can teach the courses. And the university would say, well, we don't necessarily have the people to teach the courses. So I taught quite a few and updated the courses. And, you can't really fire a teacher for not completing a certificate when the courses aren't available. So there's these really interesting opportunities and barriers when you do this kind of thing. But the great thing that occurred is that I was literally able to kind of see what my teachers needed to learn, and then to figure out how to structure a course in order to provide that, and then set that course in the context of a broader program of professional development. So we know that people aren't going to be able to walk out of a course and be able to implement this. So how do you ensure that that the schools can provide the coaching and the support to really solidify these new practices? So that was kind of one context, and those courses are still kind of up and available at University of Delaware in their School of Education. The second opportunity came when Lehigh University was looking to add some, to update their courses and add some online ones. So I created a course that was an introduction to autism that was based on a couple of, based on some of the work that I've done. And that included, basically included this component where we would teach people to teach teachers and other related service professionals to know where to look for the evidence-based practice, know how to read a research study. They had assignments where they had to identify a practice that could be applicable to one of the students that they're working with, and then basically develop a plan to kind of train everybody, to make sure that everybody is trained in that practice, and a plan to evaluate the effectiveness of implementation. So that is, I think that course is still being offered at Lehigh. It's still being, I think it's probably called an Introduction to Autism. It's a master's level seminar. It's online, which I think actually, as we were talking about before, I think there are a lot of great opportunities when the online offerings are done well. And you keep the class size small, and you give people an opportunity to have discussions amongst one another and to produce projects that are relevant to their daily work. And that's what we tried to do in that seminar. And I think it's probably a course that still has to evolve a little bit. I taught it 2 different times, and then Lehigh continued it. But I think it's a great way to reach teachers who are out there in the field right now.
The next question that came in is, while we wait for EPBs, for severe aggression, to become more widespread, what do you suggest?
Well, it would kind of depend on the setting, because the opportunities are going to be different, whether we're talking about a school setting versus a what I call a wraparound service, a behavioral support program that might operate in the home. The good news is that I think in most schools in the US, they've been, some of the leaders have been exposed to the benefits of more proactive behavioral planning, right? So you have a lot of, there's been a general recognition that discipline doesn't work, that you need to kind of look more broadly at the reasons for any kind of problem behavior. And so I think there's been an important attitudinal shift, But usually what is missing is, it's just much less certain that the individuals who are working directly with the student have training in some of these more significant behaviors. And so, some of that, and the problem is that training in those different kinds of techniques is really variable. And the availability of support personnel is also really variable. So will you have a school psychologist who's really up to speed in some of these practices with respect to more significant aggression and self-injury? You don't know. I mean, there are a lot of schools now that do hire behavior specialists and behavior analysts. And I think definitely, they're going to have a lot of tools in their toolbox to be able to get a good start. So if you can access one of those professionals, if you can identify, some training programs to try to get yourself up to speed. But there are a lot of things that that schools that tend to be natural triggers for some of these behaviors. And a lot of it, the first things that I'll often look at is the setting and the task, right? So there are a lot of kids that are triggered by different kinds of settings. I mean, if I'm out in the community and there's a loud noise and my daughter is walking beside me and she's not having a good day to begin with, she'll turn around and she'll grab me or hit me or pinch me. That's just a trigger, right? And so learning to what kinds of things will set off some of those behaviors. And likewise, tasks, there are certain kinds of tasks that will trigger behaviors pretty reliably. So there are some places that you can look to at least kind of get a sense of the more obvious triggers for some of these more significant behaviors. And, just having, the opportunity to shift somebody into a quieter setting where the demands are lower or the demands can be more readily controlled is a quick solution. But the issue is that once you remove people from these kinds of more integrated settings, it can become challenging to get them back. But as a first step to at least decrease behaviors to a manageable level, that's often a good place to start. I actually have just a quick note on that, which is kind of funny. I had our school staff out as part of my daughter's transition in our home for the first time in 21 years of education. We never get school support for her. It's just remarkable. Anyways, their comment was how much lower her behavior rates were in the home setting. And it's all because there aren't the same level of triggers in the school. And because we have more flexibility in terms of the demands that we make on her, it has an immediate effect on some of the behavior rates.
Just waiting to see if there's any more questions. If you have a question, please put it in the chat.
While we're waiting for a question, I'll just kind of make it another way to make the pitch for this type of population is, there's been a couple of times over the last couple of years where I've gone to programs that serve kids with pretty significant levels of disability and challenging behaviors. And what's really interesting is when you see the parents gather and they bring their kids. I'm thinking specifically of a program that we've set up here in our town where we give parents an opportunity to go out for dinner for 2 hours. We've organized our local YMCA to do a kind of parents' night out. And we meet all kinds of parents that we've never seen before because they are just they become kind of prisoners of their child's disability because they just don't know how to get out in the community. And this is like their first opportunity to get out. And, likewise, there was a Easter Seals sleepaway camp I did for my daughter for a number of years. And when you would see the families kind of descend on the sleepaway camp, you knew that these were families that this was their only break in the year, right? That they were otherwise completely isolated in their homes, stuck in these very rigid routines because they did not have the tools and their schools did not have the tools to keep these kinds of challenging behaviors under control. So this is a population that we tend not to see until we finally figure out a way to provide them services and supports.
Peter, this has been a great talk. I was just going to reflect just on your point about the opportunities for parent supports. You know, if you look at the published studies, the best outcome data seem to come from that study by Farley et al. In Utah some years ago now. And of course, there's a lot of things go into that, and it's always hard to know with a single study. That being said, I think part of what makes Utah such a great place for people, it's a fairly supportive community, which is good. But also, at least for those folks who are part of the church community there's ready access to respite care, apparently. It's easy to call and just on very short notice get some help. And that's the kind of thing that it sounds like a minimal step, but in point of fact, it's one of the big ones. The other big one I know for kids who are not toilet trained, those adaptive skills are so important, but toilet training is such a rate limiting step for parents. They are ashamed to go out in public with their kid, can't go to restaurants as a family, that whole package of stuff. But I think what your talk just underscores how important it is to have a real line of communication with the family back and forth.
Yeah, those are great points, Fred. So like the toilet training is a great example because we know how to toilet train. I mean, if you get in it, and it's all a matter of intensity. Like we had to do toilet training for our daughter. We had to convince our local county provider and our school to kind of change their practices so that we could have an intense period of like 2 to 3 weeks where that's all we focused on. And we set aside her goals. It was a whole thing, but it's, the evidence is really clear that there are very few kids that can't be toilet trained with that kind of intensive program. And to your other point, one of the wonderful things that we've discovered in trying to, launch services for our daughter here is that there are a lot of community organizations that want to help. They're ready. They may have a family member who has disability, so they just know that that's kind of part of their mission. And that includes churches. There's a local congregation that's been offering respite nights monthly for years. And it's just part of what they see as their community mission. And we don't think of them as kind of service providers, but they provide a service that we don't often think about tapping into, but they're there in every community in the US. Has a church, has a library, has a YMCA, has a park, and all these things can chip away and make a better quality of life for these families.
Yes. Peter, thank you so much. It's been a wonderful talk. And for people to know, we will start to post Peter's talk relatively shortly, but also starting in the fall again, we'll have our next series of calls and we'll see you then. Thank you.
Great. Thanks so much, Fred. Thanks for everybody. Enjoy your weekend.